Hello, everyone, and thank you for joining today's session. So closed captioning will be taking place during this session, and you'll find the live closed captioning at the bottom of your screen. Zoom provides AI-powered live transcription that needs to be enabled by the viewer by clicking the CC button and enabling auto transcription. Please direct any questions to the moderator via the chat function. And should you have any technical issues, please send an email to headquarters@aero.org and a staff member will get back to you. We have two esteemed clinician scientists here with us today, Dr. Renee Gifford and Dr. Michael Ho. Dr. Renee Gifford is a professor in the Department of Hearing and Speech Sciences and holds the Fred H. Best Chair in Audiology at Vanderbilt. Renee is an active clinician scientist whose research focuses on the study of auditory perception, spatial hearing, and binaural development for children and adults using combined electrical and acoustic stimulation, or EAS, via hearing aid and cochlear implant technology. Her primary professional goal is centered on improving auditory-based outcomes and ensuring that we are using data-driven recommendations for hearing, speech, and language interventions for individuals across the lifespan. Dr. Gifford's research has been NIH funded for 20 years. She has published over 140 peer-reviewed articles, multiple book chapters, and 2 books. But most importantly, however, she and her spouse, Brandon, are parents to 3 sons, and they all enjoy golfing, hiking, and travel. Thank you for joining us, Dr. Gifford. And we also have Dr. Ho with us here today. Dr. Michael Ho is a board-certified neurotologist or an ear and lateral skull-based surgeon in the NIDCD Otolaryngology Surgeon Scientist Program. Dr. Ho obtained his medical degree from Boston University School of Medicine, completed his otolaryngology residency at Wayne State University School of Medicine, and completed a neurotology fellowship at the House Ear Clinic, as well as receiving research training under Neil Siegel as a postdoctoral T32 trainee prior to joining the NIDCD. Dr. Ho has an interest in the stria vascularis and its contribution to hearing and ion homeostasis in the cochlea, and has a clinical translational program focused on identifying new treatments for hearing instability disorders, which include most notably Meniere's disease, idiopathic sudden sensorineural hearing loss, and autoimmune inner ear disease. Thank you both for joining us so much. And I thought we could get started by asking how you both became interested in clinical care and research.
Do you want to take that, Michael, or you want me to jump in?
Why don't you start, Renee?
Okay. Well, I originally, as many of us in this field, I kind of started pre-med, although I suspect many of you are MDs or on the path to MD or MD PhD. I did that for a couple of years undergrad as an economics major, actually, interestingly. Kind of realized that I was really more interested in the research side of things, really wanted to know the how, the mechanistic, and I had been counseled by a few of my professors to kind of consider research. So I actually thought I was going to go the research side of things, knew I wanted to get a PhD. My professors in hearing and speech sciences had actually recommended I get this degree in audiology just because it makes me more marketable, interestingly. Didn't ever plan to do anything with it, thought I'll get that, I can get a faculty position and, just focus on my research. Turns out I really loved it and realized really quickly that having that active clinical practice and working with patients, that really did inform my research in a way that was very meaningful, both from a researcher standpoint, but also for the patients that we serve. So that's really kind of how I kind of circuitously found my way to working in both clinic and research.
And for me, I had a somewhat circuitous route to research, actually. So I, started off, I did a combined bachelor's and medical degree at BU. So I was there for a while. And, I always kind of knew that I liked being in research and I liked asking questions and, I enjoyed the process of being a scientist, really. And, over time, I did not get an MD PhD. At the time, at the institution, I did not know exactly what I wanted. And I figured that was a bad way to start a PhD. So I didn't do that, and did research in medical school, in labs, and also in undergrad, and then did some work during my residency. But then after my residency, I really took some time to get some more research training and work with Neil at the House Clinic in USC, and then, really found my way, both clinically and scientifically here once I was at NIDCD in the Surgeon Scientist program, that was originally kind of spearheaded by Carter Van Was and Andy Griffith. And so, I think that, surgeon scientists, clinician scientists take the problems that they see in their patients and bring them back to the lab in whatever setting that is. And I think that is what separates us from solely PhDs, and it's a strength, and it's a strength that I think we as clinician scientists have to really rely on and use to distinguish ourselves.
Thank you both for your responses. I think it's inspiring to see that there's no one direct path into being a clinician scientist. Can you tell us a little bit more about your clinical or research areas of focus and how you became interested in that?
Yeah, sure. I guess we'll just do the turn taking again. So for me, so as an undergrad, I had a great opportunity to volunteer in a number of research labs, and very quickly on, I volunteered in Michael Dorman's cochlear implant research lab doing speech science work as an undergrad. I also worked with Sid Bacon in psychoacoustics, really working with individuals with normal hearing, studying kind of the temporal processing properties of the auditory system. Loved both of those things, but didn't ever really see myself working in cochlear implants, which is kind of funny now looking back. Really loved the idea that we could kind of look at the physiology of things, but through behavioral methods. And so had that opportunity upon the counsel of my professors, went and got the, wasn't the AUD at the time, I got the master's degree, knowing I was going to go into the PhD program. And then along the way in my master's program, I really liked working with children in hearing loss. And I loved the whole process of how we could potentially shape their, auditory speech language literacy development through the use of these hearing technologies, hearing aids, bone anchored implants, cochlear implants. Took that information and really kind of start thinking, okay, we have this great literature in this space that's really largely driven by the research, right? Like researchers, not necessarily clinician scientists. And we had really great clinical practitioners who were working in this space and helping these families and children, but there wasn't a ton of cross-pollination across those two areas. And so that's really kind of was my goal from day one. And even though I had worked almost exclusively with children in my clinical fellowship, when I went back to get my PhD, it was exclusively in adults, because that's who, what the population that my mentor had worked in, Sid Bacon. But always was the goal, let's bring this back. We're going to understand things in the adult population first, as often is the case. Usually it's sort of animal, adult, children, and knowing I was going to go that way. But that's kind of what sparked my interest that way.
And, for me, in terms of, I think I became really fascinated with hearing during the course of my training and residency. And I was always struck by really how there are some diseases that we've been treating for, over 40 years the same way. And, I could see the divide just like Renee can see the divide between basic scientists and, expert clinicians. And really wanting to really bridge that gap is what drove me to pursue the path that I've chosen. And I don't know if you can tell from both of our demeanors, but we both really love what we're doing. And I wouldn't have my life any other way, even though it has its challenges.
Thank you both. I want to open up the chat for questions. If anything comes up, feel free to drop them in. But just to keep us moving along, can you tell us a little bit about what your typical week looks like as a clinician scientist?
Yeah, typical. There's no typical, right? And so really every day is very different. And I'm very thankful and very lucky to have the position that I have. So I really kind of build my clinical practice how I want it, which is really a great luxury. So I don't really have a clinical template. I kind of see patients on an on-demand basis. I kind of am the resident. I will see people when nobody else kind of knows what to do with them. And so that's kind of my specialty clinic, kind of like the poor performers, the more challenging, complex patients. My clinical practice is really across the lifespan. So I see, really everybody, children, adults, older individuals using cochlear implants and hearing aids. That's my specialty. And so I typically annualize, I would say I see about patients really only a half day a week, but there are weeks where I'll be in clinic 2 full days. And then there's weeks that I don't see a clinical patient. Although a lot of the work that I do in the lab is also highly clinical. So, programming of cochlear implants, hearing aids, verification of the technology before we do any type of, experiment and assessing the outcomes associated with that intervention. And so again, it's just, but I think that's also what's exciting about it. Every week is different. I'm not really in that grind that every week, like this is the same thing every single week. So, I'm in clinic usually on Wednesdays, but I see patients all the time. I teach, I have a lot of students in the lab that I mentor. It's a great profession. I'm like with Michael, like I love what I do. And I couldn't imagine doing just clinic or just research. It's really, it's so exciting.
Yeah, I think my ADHD would set in if that happened. But my week is a little more regimented, but also varied. I have tried to compartmentalize a little bit. So I have my clinical days on Mondays and Fridays in general, and I have my scientific time or my lab time Tuesday through Thursdays, but that doesn't actually mean that those don't actually blend a little bit. As a surgeon, there is a certain degree of needing to maintain your skills as a surgeon. So that time has to be efficient. But I think there are challenges on both sides. I think I do spend some time working in the evenings after my kids are asleep. I got a 9 and a 12-year-old. I coached 2 soccer teams last season. So things, the rest of your life still happens around you. And, family is probably one of the most important things in your life. And I think if you remember that and try to center yourself on that, the weeks sometimes just happen. And honestly, work-life balance or like how organized it is, some weeks work better than others, frankly. Sometimes the week was a success, and sometimes the week, from my perspective, is a complete failure because everything was out of order, but that is the life. And I think that's kind of what I don't expect it to be one thing.
It sounds really exciting to have such a flexible and dynamic career as a clinician scientist, for sure. So we're starting to get some questions in the chat. The first one that I have here is, how did you find the job search as a clinician scientist? And are there any major things to look for in position postings?
I might let you lead off, Michael.
So this is what I would say about that search in particular. I would not advise you to look for postings. I would write to the people in places that you would like to be, that have the mentors that you would like to be with, because your career development grant is going to depend on your mentorship. So you need to have those people, and they don't necessarily all have to be in your same field. You want established scientists who will be good mentors, and you want a chair that's going to understand your desire and the needs that you will have as a surgeon scientist. Not everyone does. I think that's probably the most important thing there. And I'll tell you that when I was looking around initially, I wrote to places, and just met with people and that type of thing.
Yeah, that's great. I agree. I don't think that you're not going to find the advertisement of the position that you want exactly. I mean, every once in a while, but it's very rare. And honestly, I would love to say that I had this mapped out my whole life and I knew exactly what I was going to do. I got some great opportunities early on that allowed me to kind of pursue this path. So out of my postdoc, I was just looking at just regular old faculty positions, and I wanted to be able to do both, clinic and research. But pretty much everyone I spoke to, all the chairs were like, oh yeah, when you're at an academic-based institution, it's going to be really difficult for you to be able to, actively pursue both paths. You're going to really be focusing on the lab and in teaching and mentorship. And I got a really unique opportunity to join Mayo Clinic as director of a cochlear implant program. And they specifically wanted me to build a NIH research position and research funded lab. And so that was really, I really credit them as being kind of visionaries and wanting to build that. And that's really what helped me kind of launch my career. Now, not every position is going to work out in that way. I loved my time at Mayo. I had the greatest friends left over and great colleagues, but it was very, very difficult. So like Michael was saying, like the blending between those worlds. And so what was happening was clinic kept creeping and creeping and creeping and creeping more and more and more on my schedule, which could be fine. But when you have 2 R01s and you also have to, make sure that those research activities are executed, and then you're also seeing your patients, there had to be a divide. And so that wound up not being ultimately the best fit for me. So you do have to recognize that you sometimes are going to have to change maybe your path just slightly. And then that brought me to my current position at Vanderbilt, where it is more kind of a traditional academic based, degree granting institution, at least in audiology and speech language sciences. And then they also happen to have a very large clinic. So in my side of things, usually most of the training programs are associated with kind of a university-based clinic, which really, in most cases, it exists to really help the students matriculate through the system. There are other centers where it's really more like, for example, at Vanderbilt, our audiology speech language clinics exist on their own, and they're extremely busy and huge. And it's sort of like the academic program is a side to that. And so I had this great opportunity to, work in a very busy active clinic, and then also continue my research. So I think that don't feel like if you get somewhere and this isn't really working out, that sometimes is going to happen. But like Michael said, just do your best and really kind of feel people out, because there are going to be places where it's going to be easier to achieve this goal than in others.
And Ansley, I do see a question about kind of balancing research and residency program training, and maybe I'll just address that a little bit. Sometimes in certain residencies, they have, most residencies for otolaryngology have designated research blocks. But if you're very interested and you join a program that has an R20, what's now going to be an R25, but was a T32, there's often a year or 2 of research built in. And that is often a good time to kind of be mentored. Now, I was not in a residency that had that, but I did work in a lab, and I worked as a resident. You find time to work at other times of the day, so to speak. And but I did kind of, once I got out of residency, I realized that, training as a scientist requires just as much time as training as a surgeon. So there are no shortcuts. And, I think that the opportunity that I had to join the NIDCD Surgeon Scientist program really kind of has launched my career in that sense. And I was really fortunate to kind of almost fall into this a little bit. And, through my discussions with both Andy Griffith and Carter Van Was initially. And I've had a wonderful experience here and really kind of developed some really nice collaborative relationships here. So, that's sometimes it's planning, but sometimes it's just luck and being there at the right time in the right place.
Thank you. So along the same lines of thinking about transitioning between different career stages, we have a question asking whether you'd recommend doing a traditional postdoc versus moving to a clinician scientist role or junior faculty position after a PhD, and kind of how to navigate that situation?
Yeah, so I can just tell you my experience. So I don't know that I would have been successful if I hadn't completed a postdoc, but that's for a lot of different reasons. So my PhD program was very much almost, even though it was in a hearing and speech science program, my mentor was an experimental psychologist, and that was basically the degree I got. So did a lot of like signal detection theory and neural networks, and very much like experimental psych. And I just felt that even though I was already a clinician and I was using that information to kind of inform at least the research that I was doing at that point, I really needed the postdoc to basically achieve the goals that I wanted, to get back into a more clinically translational approach, working in the, the field with working with cochlear implant patients, using speech science as a guiding principle for, manipulation and assessment. And so for me, it was critical. I couldn't imagine going out of my PhD program. If I had, I think it would have been okay, but I would have likely just been just doing the research thing, not doing necessarily the clinician science thing, which of course was the goal. So, but I do know people who have come right out of their training and have gone into a junior faculty position, whether they're MD, PhD or PhD, AUD, PhD, and they've been very successful. I think that is a very individual, route to take, and you really have to explore kind of what you want. Do you have the training that you need to be successful in the space that you'd like to be? And I suspect it's also very different in the MD world. So kind of pass the baton.
So yeah, I think it is a very personal decision, and it does have something to, there is, to some degree, if you have an MD, PhD, there is, which I didn't, there is some additional training that you've already been through, and I think that from an MD PhD standpoint, we see a lot of MD PhDs who don't go on to do research after medical school. And some of that may be timing, and some of that may be length and kind of training and kind of the wear that takes in your life and so forth. But I think when you're thinking about coming out and whether you need to do some additional training, for me, I felt it was absolutely necessary. I would not be where I am today without the additional training and without the additional perspective. But that's different for everyone. And, I think the best advice I got from, Andy Griffith when I first came here was to blend or merge my clinical interests with my interest in the lab, and to kind of make that kind of the strength, so to speak, and the focus of my work. And I think that has slowly started to take shape. So I think I'm still evolving. So yeah.
Thank you. The next question that we have here is, what are some of the most challenging things that you face as a clinician scientist, and how do you confront those challenges?
This is a great question. There are a lot of challenges, and something that I think that's very important for us to be aware of, and also so that we keep those on the forefront so we can actively address them. So at least from my perspective, being in a more kind of audiology, hearing science, clinician scientist role, I have always felt that I don't really belong to either one of those worlds, right? So it's like when I'm in clinic, I love my colleagues, and I believe that they respect me in clinic, but I also know they're like, she's a part-time clinician. Like, she's going to go back to the lab, she's going to do her thing, and that's what she does. And I have felt sort of the same thing on the research side of things, whereas my colleagues primarily who are doing, in the lab full-time, mentoring students, teaching, are like, oh, she's got clinic, she's got to go back to clinic, so, and it's not like there's no bad feelings. It's just that you are viewed slightly differently than if you were complete clinician working with your colleagues in a clinical environment, clinical surgical environment, or if you were just in a research-based, like academic mentorship, education, so forth. So I do think it's important for us to be aware that it's a unique position to be in. There aren't a ton of people who are really doing this actively. So people who really do actually continue to see patients in a clinical environment, clinical, surgical, whatever that may be, and pursuing active, prospective research, trying to get federal funding and so forth. It's a hard route to get there, but if you're dedicated to it, you're absolutely going to make it work. And honestly, there's a scarcity. And so I know that particularly the NIH finds that this is, there's a lot of programs aimed at trying to cultivate the surgeon scientist, the clinician scientist, which tells us, of course, that this is not a lot of people out there, and we need these individuals because it's absolutely critical to ensure that we get this, clinically translational work brought to our patient population. So knowing that is really, for me, that's been the greatest challenge. And I would say a secondary challenge associated with that is, again, what Michael had said, these worlds will continuously bleed into one another. And in some ways it's good. And sometimes you do need to be actively aware of that and actively kind of push against. So for example, there's always push for, can you fit a few more patients in this week? Can you do this a little bit more? Yeah, I can do that. But then the research duties don't go away. And so what happens is, instead of working till 9 o'clock, maybe I have to work till 11 one night. Now I don't do that every night anymore. I used to, but you do kind of have to be aware that there's kind of some compression and expansion of those different areas in which you work. And it's going to take active participation and planning on your part to really ensure that you can fit everything within a week, keeping in mind that your family and your personal time is very, very important.
Yeah, I second that. I think that you definitely, as a clinician scientist, face the kind of the, it's not malicious or anything, but it's just that you're not full-time on either side. But you're in some ways expected to be great on both sides. And when I said earlier, sometimes some weeks are better than others, that's what I mean. And for us, medicine is healthcare is very, cut and dry to some degree. There isn't a whole lot of room for error, and progress is somewhat linear. In science, progress is often nonlinear, and your chances of success are probably on the lower side, but you expect that. And I think that the challenges we face in terms of being that dying breed, that rare group of people, is that we have to deal with both challenges, and the work doesn't go away just because you were in clinic for a part. I think it's really important to find the support systems you need, and to also develop mentoring networks along the way. I still have new mentors, and I think developing new relationships over time is really important. You can have multiple mentors for many different things, and I think it's important to kind of actively engage and reach out to people, and they do not always have to be at your same institution. And I especially think that they can be all over the place. So that being said, I think the other challenge that we often find is that, I essentially have 3 jobs. I have my job as a clinician, my job as a scientist, and my job as a person with a family. And and balancing those is hard. And I so very rarely use balance in my life, because that's not how I view it. I kind of view it in a sense of, where can I fit things in a given week, and what can I do? Some people are better at saying no than others, but early on in your career, there are some things that you can't say no to. And so you have to find ways to make that work. And you do. But I think as you get higher in the rung, there are things that you do say no to, and understanding kind of that progression is important too.
Thank you. So thinking more about this divide that we sometimes see between clinicians and researchers, we have a question asking how you might foster an environment of growth and development for clinicians and audiologists who may be interested in research but have little research experience.
Maybe I'll start with this one. I think that in terms of that, really people who are coming from a clinical environment with less research training, I think the number one thing is to get them excited about the questions we're asking, or they're asking, because that's ultimately going to be what's most important about guiding research. It's learning to ask those questions. And then those questions guide you or drive you to learn the methods in many ways in which you need to answer the questions. And, if there's one thing that I learned from, working with Neil Siegel was that, he thought the most important thing was really learning to ask the questions independently. So sometimes, he wouldn't kind of, there's some Socratic method, so to speak, of being a mentor and letting people come into their own and asking the questions that they're interested in. So I think it starts there. Whether you then go and pursue some additional training, or whether you decide that, you want to kind of confine your contributions to a certain area based on kind of your expertise. I think that just depends.
Yeah, and that is excellent advice. I think also there are really a lot of mechanisms in place that can allow you to foster that, even if irrespective of the level of research experience you have. So we know that there's the career development awards that are really designed for more of kind of like the clinician scientist or the patient-oriented research. And while they're not necessarily going to be granted to people who have no research experience, if you have minimal research experience in at least, a publication or 2 or 3, of course, always better. And getting that actually gives you training for, mentored training for another 5 years outside of your terminal degree, whatever that may be. And so if this is the kind of thing you're thinking of and you kind of are unsure, like, I don't really feel like I'm in a position to be, a principal investigator at this point, but I think I might want to, move down that route, I really recommend you be thinking about those K awards, be identifying potential mentors that you could work with in that space. There are other options though too, especially on the audiology side of things. So let's say you graduate, you get an AUD, you're not sure exactly you want to get a PhD. You could work in a research lab for a period of time. Labs are always looking for research audiologists because a lot of the work that we do does kind of require that expertise. And it's critical to the work that I do. Like I couldn't just bring in, for example, like research assistants, because they would have to be trained up so much on just kind of like all of the duties associated with, programming, verification of equipment, assessment, and so forth. So I really recommend you kind of thinking of those. Okay, do I want to get a PhD? Maybe do, a year or so of working in a lab, actively engaged in research. If that's something you want to do, great. And then be working toward whether it be a K or early career development award, or going to things like Lessons for Success at ASHA, which really gives you a nice kind of 3-day intensive career development, grant writing workshop, networking. There's lots of programs in place, through the communication sciences and disorders, as well as through the otolaryngology side of things.
Thank you both. So as 2 people who are also both mentors, is there anything that you do differently when mentoring clinician scientists compared to more traditional research or PhD students? And are there any experiences or specific kinds of training during the PhD that clinician scientist students might benefit from or need more so than a traditional PhD student?
That's really good question. Renee, you might have more experience, so why don't you start?
Sure. Yeah. So I've mentored a lot of PhD students as well as, AUD students on the route to PhD. I would say the PhD students I've mentored have been overwhelmingly those who had an AUD and then pursued it to get a PhD. But I've had a few who came through that were kind of just straight through neuroscience, came from undergraduate bachelor's or, for example, MD, PhD. And so I really do constantly want to challenge the individuals who are kind of trying to go along that clinician scientist route, that it's not just about the great research and the great scientifically motivated research questions. They have to think about, let's say for example, we're doing like a mechanistic type of study. I really am like instilling in them that, okay, how are we ultimately going to bring this to the clinic? How is this going to inform patient care? How is this going to inform, our clinical practices, maybe adoption of new protocols and so forth. So for example, like right now I have a PhD student who came from computer science, who's very into engineering. He's doing great work and we're doing very mechanistic based things. And while I feel that he has a very good grasp of how that will impact clinical practice, I would guide that project slightly differently if he were someone who was actively going to go into kind of like an AUD PhD, MD PhD route. So again, it's kind of just like really challenging yourself to bring it full circle. How is this going to impact clinical practice, and sooner rather than later? And not just because that's the sort of thing that gets you funding, which is also a nice bonus there, but it's critical. And for us to constantly be thinking, we might come up with really cool ideas. Like, I just want to know how the auditory system does X, and you can come up with those pathways, you can come up with those mechanisms. But how is that going to inform how we treat the problem at hand? And that has to be at the center of all of the, the questions, all of the hypotheses, all of the analyses. And so I would do things just a little bit differently there. At least that's how I approach it.
Yeah, and I think I agree. I work with a significant number of PhDs, both in and outside of my lab, as well as kind of MDs. And for those who, just backing up a little bit, for medical students who are interested in getting more research experience, there are medical research student or kind of years off to, programs that kind of allow you to take a year off to do research. And so that's an avenue for medical students who don't have that kind of research experience. And I've had several who've done that. And I think it's a good way of kind of sparking that interest. But to go back to the idea of, what's the difference? I think in some ways, mentoring is really looking out for the best interests of the people that are spending time with you and focusing on what they're going to need to be prepared to do in the life that they have planned moving forward. So I think that for clinician scientists of multiple flavors, I agree with Renee that you really need to focus them on how is this going to impact the patient and how does this change clinical care? Because those are the priorities that matter and that position a clinician scientist well to get funding, frankly, down the line.
Thank you. You both spoke about kind of using your clinical mindset to guide your research. Can you speak a little bit more about any examples you may have of how your clinical experience has informed your research questions?
So I guess I can start with this one. My interests are in patients with Meniere's disease and sudden hearing loss. And right now, in many ways, we have very little in the way of kind of treating how these patients experience their hearing loss over time. And so I think that seeing those patients every day or every week, and kind of knowing that is what is motivating me, and where my lab is looking for new treatments for these patients. And really that's the focus. I've told everyone in my lab all the basic science that we do is all geared towards finding new treatments, and really more importantly, all the clinical work that we're now doing is really geared towards that. And so that drives everything I do in the lab, really. And I think that is how your clinical experiences drive you. And even our cochlear implant patients, I run 2 cochlear implant programs, and those patients drive me to think about what will help kind of us do better. And we're looking for treatments for that, based on some of the data we're generating. So we're very interested, the patients you see every day are what renew your questions over time and really focus you.
Yeah, I agree with all those things. One of the things too that I learned very early on when I was doing my postdoctoral fellowship with Michael Dorman, who is not a clinician. He's a speech scientist. He, studied at Haskins Labs, very, very research-based, but he was probably more influential to me about really kind of framing things from the perspective of a clinician, interestingly, as not a clinician. So he would always talk to the patients, like really, really talk to them, not just kind of like, oh, hey, how are you doing? Thanks for coming in. We appreciate your time. Like he would be like, how does that sound? Tell me what are the things that really are bothering you on a day-to-day basis? How can we, like he really was drilling down. And I thought, gosh, it's fascinating because I hadn't ever worked with anybody at that point from a mentorship standpoint who had done other than the like, thanks for coming in. We appreciate you. And so that really has helped. And I ask, when I talk to my patients in clinic, I'm asking them lots of different questions. So if I see, for example, so one of the areas of expertise I have is in electroacoustic stimulation. So people who are using hearing aids and cochlear implants, both within an ear and across ears. And I'm going to ask them, how about this? How does this work? What are some of the challenges you experience in the real world? And of course, these are questions we would ask anyways, but I'm really, really trying to get at some information that not only is going to help me improve things right then and there in that clinical appointment, but are things that I can take back to the lab and really start to investigate. And in fact, interestingly, that sort of thing is what has brought me to my current area of expertise. So my PhD training was completely in monaural hearing. Completely like peripheral based monaural cochlear. And I am now really working almost exclusively in binaural hearing at this point. And it's directly related to my experiences working with the clinical population that has really forced me to think about what is driving this benefit that we're seeing, because nobody was answering these questions. Like we knew that people were getting benefit from this particular intervention, but we didn't know why. And why was that important? Well, it's important because not everybody gets that benefit. So we need to understand who are the ones who are going to get it and what can we do from our perspective to drive that benefit even more. And what about those people who don't get it? Can we identify why? And now the part that I'm at is, can we improve that? If they don't have, for example, a specific skill set, whether it be, binaural cue sensitivity, because that's something we could train. Is it something we could improve by maybe changing the parameters of their hearing aids and cochlear implant? So again, just talk to your patients, really, really ask them the questions, really get interested. They're going to tell you things, especially the parents too. Like if you're working with children, you really, really learn a lot from that, from those individuals who are living that.
Thank you. I love the advice of listening to your patients. And kind of on the flip side of that, how have you been able to translate your research into your clinical practice or your interactions with patients?
I'll jump in. So mine's probably easier in some ways, just because the work that I do in the lab is almost identical to the work that I do in the clinic. So for example, if we're finding something is, so early on when we were finding that, binaural cue sensitivity really did influence degree of benefit with this EAS processing, we decided early on to let's experiment with some of the overlap of the electric and acoustic regions. Let's, experiment. And so we were doing that in the lab in a very systematic manner, but we started seeing trends. And so what I would do is bring that back to my patients and start, kind of implementing some of those changes and ask them, well, so what do you think about that? How does that sound? And then we would test them in the sound booth. And so that was a way that I find it's really exciting that I can take almost direct, immediate translation from some of the things we're observing in the clinic and then take that, and from the research lab and take that to the clinic. And so I feel really grateful that that's an opportunity that I can take advantage of really every time I'm with the clinical patient. And so, of course, I always mention, this is something we're working on in the lab. This is not necessarily something we would do for every single patient, but, if for the right patient, if they're willing to spend a little extra time with you, and you have the time, of course, from a clinical standpoint, you can learn a lot, and the patient can get sometimes immediate benefit, which is really exciting.
And I think as a surgeon scientist, there are definitely some things that we're doing in my lab that have prompted the development of some treatment trials that we're working on, kind of putting it, starting. And I think that we've also started to employ in our clinical protocols some advanced imaging that is helping us get a better idea of diagnosis and sorting out the diagnosis, because we think patients with both sudden hearing loss and Meniere's disease might actually be more than one disease, each of them. So there's, I think our experiences in seeing and dealing with a lot of heterogeneity in the data that we see and the experiments that we do at the bench have also kind of given us a backdrop for kind of understanding heterogeneity or differences amongst our patients. And so I think that's really one of the things that we take. And when I'm in clinic seeing patients, I think that really informs how I deal with my patients too.
Thank you. So we've had a couple of questions come in related to collaborations. Both, how do you develop collaborations between other researchers or clinicians, both at your institution and at other institutions as well?
Maybe I'll chime in here. I think that initially, when you're first starting out, oftentimes you're mentored, so you do have some ready-made collaborations to some degree. That doesn't mean your mentor is going to be your main collaborator. It means that there are networks that you can take advantage of. And so I think those are good places to start. Going to meetings and presenting your work and talking to other people are great ways to develop collaborations. And for me, that has been one of the ways in which I think some very fruitful collaborations develop. And really having a scientific community, clinical scientific community where you are is really important, because that's how some of these collaborations start. They start just as discussions about your work and about other people's work, and kind of questions arise from that kind of develop into collaborations.
Yeah, I agree entirely with everything that was said. I think also some of this just kind of happens naturally, organically, just from, being at your institution, or like, as Michael said, at a conference, and you're talking with people who have similar ideas and thoughts, and you just kind of think, we should be working on a project together. Sometimes also I've gotten some really great collaborations over the years because I just chat it with people at conferences and then go home, think about it, and then I'll just reach out to them, email, call, however it is, and just say, can we set up a call? I'd love to talk about this. And now I have grants with some of these people, and we have publications, and it really just expands your network. And I just look at it also, it's not just for us and it's helpful for us. It's helpful because we're bringing in this diversity of thought in these different areas of expertise. And ultimately that's going to be beneficial to the patient population. So I think sometimes you just have to get kind of out of your comfort zone and really just approach people, which is easier for some people than others. I'm definitely not one of those people. I kind of get nervous about, especially kind of the cold calling, and I don't recommend necessarily cold calling, but if you've talked to someone at a conference and you feel like, hey, let's maybe potentially try to develop this, go for it. It's not always going to work out, and that's okay. And sometimes it works out beautifully, and it can be a lifelong, scientific, teamwork that it results from that.
Thank you, guys. So Dr. Ho, earlier he mentioned this concept of kind of having 3 different jobs, as someone with a family, someone with a lab, and someone with a clinic to keep up with. Is it challenging to balance your time between those, and how do you kind of approach that challenge?
So I think I view my week as a kind of a grid, and understanding where certain things like, and your partner, whoever that is, if you have a partner, that for the family side of things, that's understanding where those priorities are and trying to make it work. But I would say that there's some weeks where I don't really succeed at balancing that. And but I think it's, as Renee said earlier, there is a constant kind of just attention to where you fit things, and trying to kind of confine as much of those individual things to the silos or the areas of time that you want them to be in, knowing that nothing's perfect, and giving yourself maybe a little grace to understand that you're trying your best, and that it's not always going to be every week's not going to work out exactly. But I think also on the flip side, that is exactly why people like me love this life, because not every week is the same, and you get variety, and you're constantly engaged. When you get a little frustrated on one side, you have the other side to really engage you. And I love the process of science. Not just the results we get, but I think as a clinician scientist, you absolutely have to love that process. And I do love it. I think that it's really important, and I think that discussions and kind of having colleagues that you build these relationships are really important to that. But in terms of balance, I just try to fit things where I think they're going to fit, and I hope for the best during the week. And usually it works out a lot of times. I've gotten a lot better at it over the years, but it's a learning process.
That's such your last statement is so, it just hits a nail on the head. I've gotten better at it as well. And I would say, I almost wish I could go back in time, like the last 20 years, and just kind of apply the principles and the time management strategies I've, kind of, I wouldn't say perfected, because they're nowhere near perfection, but have definitely improved. There are times that you're going to have to just get really kind of serious with yourself, because if you're someone, I suspect everybody here, they're all type A workaholics, right? I mean, these are the people who go into this. And so we're going to keep pushing ourselves and pushing ourselves. And there comes a point where there's only so many hours in a day and only so many hours in a week. And what do you need to fit in there? And what do you want to fit in there? And I was someone who, let's say I'd have a day, it's like, this is a day I'm going to be working on my grant, or I'm going to be writing a paper. And I would view that as my time. And if a patient needed to be seen, or if something came up, I would immediately put him on that time. And, kind of thought, well, this is my flexible time. Well, it's flexible, but it's also necessary to get the job done that I need to get done, right, in order to continue to be successful in my area. And so I know it sounds a bit cliche, but you do have to put things on your calendar. Sometimes you have to block entire days, half days, in order to get the work done that you need to get done. And you have to honor that time. And I say that as someone who hasn't done that well over the last, couple of decades, but I'm getting better. And like Michael said, grace, you have to be kind of forgiving of yourself, because you're going to make mistakes. You're going to have weeks where you're working like way too many hours than you should. And you're going to just feel like a failure, and you're not. And just knowing that we're always trying to just do the best we can, and we're always trying to improve. So that's the best I can say.
Thank you both for that advice. I think it's encouraging to see that despite all these challenges, you both seem to still love your jobs. Can you describe your most exciting moment in the lab? Or one of the more exciting moments you've had?
I guess this may sound a little cliche. I think that I get really excited about results, but also I think I get excited about just being able to come in and talk about work. And honestly, the chance to talk about the work that's going on is usually the most exciting thing that and if you had me choose what I like the most about being in my lab on a day-to-day basis, it's going to my lab meeting and talking about the work we're doing. I love that we encounter problems because I expect it, and then we get to solve and figure out ways to solve them. And when an experiment, of course, when an experiment or some data comes in that you're really excited about, that's amazing. But I think that what I've learned over time is that that process really has to excite you. And that's what I get excited about, and what brings me into work every day is the opportunity to talk about our science and our work that's kind of directed to, finding new treatments.
That's a great point. Yeah, I love talking about it as well. And in fact, I always challenge, students to think about the things that really get you excited about things, right? And make note of that, write it down, because these are the things you're going to want to pursue. So like for example, there's some things I go to a conference, some conferences completely energize me and get me so excited to just jump back in the lab and can hardly wait to get on the plane. And then there are others I'm like, I don't know, yeah, I learned some stuff and I met some great people, but maybe not as, encouraging or inspiring. For me, I wouldn't say I love our lab meeting very much. I love meeting with everybody individually. So like I meet with all the students pretty regularly and just talk about their projects. And that's the stuff. Oh my gosh, I just love that. Really diving in deeply to get into that. You had asked a question, Ansley, like what the most exciting part in the lab. And I can think of two specific instances. Now these happen to be related to the same project, but it could be any project. So one of the areas I've been working on is collaborating with my colleagues in engineering, and we're using this CT-based, image-guided approach to cochlear implant programming, really just trying to clean up some of the channel interaction that we know potentially stands in the way of auditory outcomes. And so years ago, when we first implemented this was like our second participant. And we were using, just moving forward very systematically, brought a participant in, provided the image guided programming. This is someone who was bilaterally implanted, had one ear that was like performing about 30%. The other ear was like 88, like top of the line. And we're like, okay, we're going to try to fix that ear. And so we implemented this programming approach. And I wake up in the morning, I have an email from this person and it's like this long. And they're like, I swear, whatever you did, fixed it. Like I talked on the phone last night with my mother and I used that ear and I would have never been able to do that. And I'm like, yeah. Like this is like a placebo effect. She's really excited. Experimental bias. Yeah. So she happened to work at Vanderbilt and I was like, just, can you come on in and we'll just do some quick testing. And she came in and her performance had gone from like 30 to like 70 overnight. And it's not so much the success of the intervention, but I love bringing improvement and improved quality of life to our patients. I'm deeply committed to it. I love, I just love this area of research and clinical experiences. And so we also had a similar situation with a child a few years ago where the parents like, his friends can't understand him. His teachers are really struggling. He's really, really struggling. Applied this intervention. And then 4 weeks later, like got notes from the teachers, got notes from parents, hear from them and they're in tears, like how much he's improved. And so like, honestly, that is like the stuff that just keeps me coming back. Like if at the end of the day, all I can do is just help people improve things, that I'd be thrilled to do that for just the rest of my life.
Thank you, Ian. I want to encourage everyone to put any questions that you may have in the chat. Another one that we have here do you have any specific recommendations for international medical graduates or international scientists who are interested in becoming clinician scientists in otolaryngology, since there may be limited research or clinical opportunities for them?
Yeah, so, that's a good question. I think it is harder, having been both on I interview for our residency and kind of understanding the challenge of being an international medical grad and applying to otolaryngology residencies. Now, there are some residencies that outside of the US that require, or where there is a requirement to do research. So, so I do know that some of those exist too. And, but I think, you know, as far as kind of some concrete recommendations for what you should do, I think you have to reach out. And you know, if you go to a meeting like ARO, it's a perfect opportunity to talk to the people you're interested in talking to. And I know that that's sometimes hard because, you know, culturally, I come from a culture that is very reserved, and I had to learn to be different to some degree, and I'm still not different, really. I'm pretty shy. I'm on the shyer more introverted with people that I don't know to some degree, but these meetings are a good way of you getting to interact with people and, you know, investigators and scientists and surgeon scientists. So I guess that's what I would say. And Renee mentioned earlier these conversations on the side. And I would say that's one thing that I'm really looking forward to going to an in-person ARO, is that really us being able to have these side conversations next to a poster in the hallway. This is what these are the conversations that I think help us develop new relationships and collaborations and meeting new people. I think these are all kind of part of the unsaid and intangible parts of this meeting.
Yeah, I can't offer much additional, but I've had the opportunity to not directly mentor, but work with a team of mentors of some international clinician scientists who've come over. I believe it was mostly after they completed their medical training and then did like a year or two of a kind of a research-based fellowship at Vanderbilt. And I believe all of those had originated from the fellow just reaching out to people like at a conference and talking, and, you know, and then sometimes we have grant funding that we can apply and actually pay like a fellowship type of experience. And then sometimes like individual governments will provide some, you know, funding to help further the education. There's all different potential ways to make this, you know, financially doable, but it does start with conversations and reaching out.
So we've briefly touched on different research opportunities for clinical students or clinicians, like the T32 or R25 programs, or taking a research year. Can you speak a little bit more about what opportunities exist in that space?
In terms of the research year, or all three?
All three.
Okay. Traditionally, residencies have had, or some fellowships have had, T32s, which are kind of research positions built into residencies, so to speak. Those are being transitioned to a new mechanism called the R25, and I think Renee's may have a little more familiarity with the grant mechanism there, but I can talk about research years. There are a variety of ways to pursue research years, and there are a lot of different residencies and institutions that now offer them. There's a trend in otolaryngology for students to pursue research years now. I would say that that's not for everyone. I would also caution against people thinking that they need it to get into an otolaryngology residency. I think what we want really with these research rotations or research years are, to some degree, we want people to be excited about the research they're doing. I don't think that everyone that does a research year is going to end up becoming a clinician scientist. But I do think that having an appreciation for research is really important, and feeling like you've contributed is also really important. So and I would say that project choice, regardless of the length of your research rotation, is very important. So I take a lot of time when I'm working with my residents and students to think about the project that fits within their time span, and what they're capable of. I think that those things have to be taken into account, because it matters. Someone who's going to spend 2 years in the lab is different from someone who's going to spend a year or 4 months or 6 months. So, those things have to be taken into account. And but there are opportunities across. A good place to look at where these opportunities are on NOEG, the NOEG site, and the Matt Carlson's, for lack of a better term, the website that he and his team at Mayo run. So, there, and Otomatch also has some information there too. And then sometimes just reaching out, because I think some places have funding and you just don't know it.
Yeah, I don't have obviously as much experience not being an MD, but I have mentored a lot of resident research projects. I would really recommend that if you're someone who really wants to get in, like, let's say you only have 3 or 4 month rotation, which it's not uncommon in some of the residency programs, if that's what you have. You have to be really judicious in who you choose as a mentor, because you have to pack a lot of information, right, in that time. And you might have to really not shop around per se, but really kind of get to who's going to be the mentor that's going to help you achieve what you'd like to achieve in the time frame that you have. And it's, having mentored a lot of residents, I've seen the residents who you can immediately kind of see, like, this person's going to go on and they're likely going to get a K-23 and likely then get an R-21 and R-01 and so forth. And then others who are great, brilliant and do great research work, but it's sort of like they're there because they have to do the residency, the research rotation. And then I sort of feel like there could be, in some cases, you see people who really want to do research and are interested, but they've been kind of influenced by the experiences of the individuals in their cohort, I guess, like their whatever, PGY3 or whatever they are at that particular stage. So I think it's okay to be a little different in pursuing slightly different research projects as compared to your members of your cohort. But you really have to be pretty careful about who you reach out to, because you don't want to do, like, for example, just another retrospective review, and you really want to dig in. Sometimes you can do a retrospective review that's really, really directed and very, very, useful. But sometimes, they want something, and then the project that they did wasn't really what was going to get them to the next phase. So I think, again, it's really a lot. You kind of have to be really calculated about how you're going to approach that and who you're going to work with.
So along those lines, do you have any advice for finding a good mentor, or certain qualities that we should be looking out for, or qualities to avoid, perhaps?
I would say, we have our applicants talk to our residents, talk to the mentors' trainees. I think that is one of the most important things you can do, is to talk to their trainees, their postdocs, their grad students. It gives you an overall flavor of their bent as a scientist and as a mentor. And you can often get a sense for that. And if they allow it, if you're able to talk to them in informal settings, that's often the best way to do it.
I agree entirely. That's what I was going to say. Very, very important.
And we have another question in the chat asking how you would recommend keeping contact with mentors who are not at your institution. For example, someone you might have met at AERO. Zoom
meetings. Now that we have this capability, I think Zoom meetings are great. I have a lot of Zoom meetings with people who aren't at my institution, and even medical students and residents who are kind of maybe not always at the same location. My cochlear implant team we have regular Zoom meetings. We meet in person sometimes, but we also have regular Zoom meetings. So I think our modes of communication, there's a lot of them now, and we should use them.
Agreed. I think now is so much more, it's so much more accessible than it was even just 3 years ago. So I would say so I've been on the receiving and the giving end of the mentorship here. And so for a few years ago, I started to really kind of seek out mentorship from Ruth Latosky. And so not really formally, I didn't ever ask her, will you be my mentor, external, but sort of we just were talking, we're in similar areas of research. And so I would say, hey, can we meet for lunch, or can we go have coffee if we're at a meeting? And then just kind of reaching out to her, can we just meet and chat every once in a while? And now her and I are co-investigators on a grant and we're working together. And so sometimes these experiences can really evolve into something really very meaningful and useful. But I will tell you, you do have to, don't be discouraged, because typically if someone you're seeking out as a mentor, they're very, very busy. And many others are also seeking out those opportunities for that individual. So you have to be, I wouldn't say annoying, but persistently not being afraid to kind of reach out, and not being don't take it to heart if they don't get back to you. Reach out again. I always tell people, if you email me and I don't email back, it's because I didn't see it. Text me, reach out any way you can to reach out, because it's completely unintentional on my part. I don't want to ignore any messages. So definitely just kind of take the ego off the table and just keep pushing, and it'll work, and you'll get someone who really will work with you. And it's when it works well, it works really well.
Yeah, I agree with that. I think that sometimes our non-response to emails is not because it's not because we don't want to talk to you. It's that we've lost track of that email. We literally get tons of emails, and we're sometimes just trying to make it through. But be persistent, and I think usually I'll reply if I really think that, in the negative, if I really think that there's nothing. But if I haven't replied, it's potentially because I'm still thinking about it, or because I haven't seen the email for some reason or another. So
I think that's a great advice. Thank you. My next question was, do you have any advice for future clinician scientists, just in general?
Renee, you want to start with this one?
Yeah. I mean, all the things we said, but one of the things too, I would challenge you to kind of check in with yourself regularly. So I do this a lot with myself. I wouldn't say I'm a journaler, but some ways I just write notes to myself and then I save them on my computer. So that's not a diary per se, but kind of you really kind of have to ask, why am I doing this? What am I interested in? What's my end game? What do I want to do? And everybody's, anybody that's a clinician scientist, they all have slightly different careers and all slightly look differently and are executed differently. So are you someone who wants to be a principal investigator and, directing your own lab and getting extramural funding? Great, then you're going to pursue that. You might not always be that person, or potentially you might get down that route and realize, oh, you know what, I might want to go a slightly different route. And that's okay. Knowing that you can change your mind, and kind of your motivation and your interests are going to wax and wane over time. And that's totally normal. So I would definitely check in with yourself regularly. Write notes, write goals. Goals are extremely important. I'm huge on that. Yeah, I think those are the main things I could provide. Yeah,
and I guess I don't know. For me, I'm a big checklist person. I like having things to check things off. So on my home desk, my home office desk wall, or whatever you want to call it, I have a little piece of paper with things that I need, that I want to get done in the next month or something like that. And some things that I want to get done sooner are higher up on that list. And that helps me in my day-to-day. I think for me, checking things off is a morale booster sometimes. So that's one thing. I do think that thinking about because your priorities are going to change over time, and your life as a clinician scientist will look different over time. And so understanding how your priorities are changing and what you're excited by and where you want to go next are, I think, really important. And that takes a lot of just introspection and just sometimes time to think. And so I would say that having some time every week for you to just, I don't want to call it procrastinating, but I will say that sometimes just sitting and thinking to yourself and having that time to yourself is really important. So give yourself some time every week to do something like that.
Yeah, and as you were talking, Michael, something else came to mind that I want to address is that I really encourage everybody to not allow others to put limitations on them. This is something that happens in every facet of life, but especially because being an active clinician scientist, so you're actually doing both of those things regularly, it's a little unique, right? I mean, if you can kind of think of the mentors and the people that you work with, there are lots of people who are great in clinic and they're great scientists, but they're not actively pursuing both of those lines. And so you're going to get people who inevitably are going to encourage you or try to discourage you from doing those. Like, oh, it's going to be so difficult to be good at both of those things. You might want to kind of pick and choose. Or I've heard this, and granted, I'm older than all of you here, but I'm not that old. And I've had people, over the years, as I was having children, like, well, I mean, at some point you're going to have to choose because, you've got this family and you can't do everything. And, or I actually had one of my former mentors when I took that job at Mayo Clinics, my first job right out of my postdoctoral fellowship. And I believe the term, I could be misremembering, was career suicide that they used to say what I was doing. I would never be successful in a research career because I was going to a primarily clinical institution and it would swallow me up. So it's kind of funny in hindsight to think about the things that people have told me. There's, and it will happen because, there's people of all generations and unfortunately there's still a lot of, sexism and ageism and all types of isms out there. And we just have to fight against it, and like, if someone tells you you're not gonna be able to do it because you want to have a family or because you're, going to have a child, just, smile, thank them for their time and move on and proceed forward. You can do it. You can absolutely do it. And just don't get discouraged.
Yeah, I think that's totally appropriate here because I think probably the number one strength of a clinician scientist is the fact that they follow their gut and they learn not to be discouraged. I think science teaches you that failure happens all the time and that you have to get used to that. And to the same degree, it sucks that people tell you that you can't do things, but I think Renee and I and others have learned that we have to stick with it. And I think that is, and inevitably you're going to get some bad advice along the way. So you need to, I think it's a good reason to have multiple mentors, and it's also a good reason to trust yourself.
Absolutely. And thankfully, you've got a group of people that you can lean on too, right, for spARO and kind of share your experiences and lean on each other. I really wish that there was something, at least, I mean, this might have existed when I was a PhD student, but if it did, I wasn't aware of it. So, it's tremendous that you guys have these opportunities and this network of people like yourself at similar career stages. So really take advantage of that.
That was really inspirational. Thank you both. I also want to make a quick plug for the spARO mentorship program. If you are looking for a mentor, you can sign up on our website and we can pair you with a clinician scientist or whatever form of mentorship you may be looking for. We don't have any more questions in the chat. I'll give a few more moments if anyone has any last questions. Okay. If not, I want to thank you both so much for your time and for sharing all of your wisdom with us. I feel like we all definitely learned a lot and have a lot to think about moving from this session. So thank you.
Thank you so much for having us and inviting me to this. I really appreciate being able to kind of share our experience, but also learn from everyone else.
Agreed. And if anybody has any questions or you just want to reach out independently, I'm always, I welcome that. So look forward to hearing from you or seeing you at ARO in a couple weeks.
Ditto.
All right. Bye, everyone.
Everybody.